I can see we are joined by a lot of people, which is good. The network is increasing by the day. We want to welcome everyone. A special welcome to people who have switched on their cameras or at least put on a picture. I can see Mwenya. Charles, you are doing well. It will not swallow your bandwidth. You know, it helps when you see someone's face. Of course, our expert for the day, Dr. Albert Mwango, we will be formally introducing him in a short while. Peter Singongo, you're always here. It's nice to see your face, though you're wearing a mask, which is a good thing. Chimwemwe, Galaxy S7, please rename your device. Special welcome to some of our facilities, which include Kaoma District, Kabwe Central, though there is no one in the room yet. I can see Kazungula has joined us, St. Francis Hospital, you're welcome. I see that Kanyama has also joined us. Of course, we have a lot of personal connections, which is expected in light of the COVID-19 pandemic. We have the TB Eco Coordinator. We have Wedi Silomba. Mr. Silomba, you are welcome. We can see that people still don't have their cameras on, but we humbly appeal to you that at least at the beginning, you switch on your camera, then maybe you can switch it off later. A special welcome and special mention goes to Dr. Kankasa. She's joined this session. She really helped us and led us as we were starting the ECHO program in Zambia. She was very instrumental. Dr. Kankasa, you are welcome. I can see Dr. Kalasa has joined us. He's one of our experts. Retention is a big deal, so I'm glad that the turnout is actually good. Before we go to today's session, Dr. Mwango, allow me to give a brief recap of last week's session. I'm not a pediatrician, but I'll do my best. So last week we had Dr. Mubiana, a seasoned presenter, and she really took her time to take us through the Zambia National Guidance on please mute your microphones. We were also able to share some best practices in order for us to increase the success, the EID testing. As you know, the pediatric surge wants us to at least have more than 90% of those babies tested for HIV by the time they are 2 months. At least they should have had one test. So as the program is doing better with reduced mother-to-child transmission, unfortunately, the positive predictive value of these tests become less. What do I mean? It just means that your likelihood of false positives goes higher. This is not a scientific issue, it's mostly epidemiology. That's why you have to make sure that if you get a positive, please confirm it so that we do not end up with babies that have false positives on treatment. This does not mean that you stop the treatment, you just repeat the tests. And we are being encouraged to confirm these tests. The lab remains our main resource, but we need to be turning to point of care or near point of care technology, such as the MPIMA and the Gene Expert. Remember, up to the age of 9 months, the main mode is the nucleic acid testing. After 9 months, it's mostly serological. This testing goes on up to the age of 2 years and up to 6 weeks after breastfeeding, because we know HIV can be transmitted through breast milk. Dr. Mwango, you are welcome. I hope you can hear us very well. Your video is good. It feels like you are here with us. Please go ahead. Yes, you are. Please go ahead and introduce yourself.
Right, I will set up the sharing so that
Thank you. For those that want to reserve bandwidth, you can switch off your cameras. Then when the presentation is done, we can switch them on.
Thank you so much, Dr. Sombo, and thank you so much to everybody who have joined us this afternoon for this session. And we'll be discussing one of those important areas of HIV programming, and that is retention in HIV care and treatment. Right, these are my credentials. I'm currently working with CRS, EPIC 390 project. I have no conflicts of interest to disclose. Only one declaration, and that is that the comments that I make, the opinions I express, and the thoughts I share in this presentation are solely my own and do not necessarily reflect the official policy of my employer, CRS, or Ministry of Health Zambia. Our learning objectives for this afternoon in this session are these four. We will define what retention is. We will discuss as much as we can what M&E is pertaining to retention. We will discuss the common retention gaps and also outline the strategies to improve retention with a key consideration of various ART populations. So to get us started, we'll start with the first poll question. Dr. Sombo.
Thank you so much, Dr. Mwango, for that introduction. So here are our poll questions for today. Retention in HIV care focuses on A, clinical outcomes, B, how long a patient is engaged in care, C, all of the above. We have 225 connections. Please go ahead and cast your opinion. Retention in HIV care focuses on A, clinical outcomes, B, how long a patient is engaged in care, C, all of the above. What is the focus of retention? Keeping people in care. What's the focus? Do we talk about their outcomes, meaning suppressed, dead, lost to follow up? Or do we talk about how long they have been engaged? Are they with us for 3 months, for 6 months, then they default? Or both of these are important? So we have the votes here. Dr. Mwango, I'll go ahead and share. We have more than 50% of the people polling. So this is this should give us a good idea of people's thoughts. So as you can see, most people felt that both of these are a focus of retention. However, there's a small percentage that felt that the focus of retention is just clinical outcomes, while 12% of our network felt that retention is just about how long a patient is in care with us.
Right. Thank you so much, Dr. Sombo. And thank you so much to the network for sharing their opinions on this subject. We will go into the next set of slides just to see how well we have responded and what the thoughts are. Right. We'll start with the definition of retention. Retention is engaging regularly a patient in care with a view of achieving specific clinical or health outcomes. So that is the definition for retention. What we have here is a depiction of the continuum of HIV care, which starts with HIV diagnosis and ends up with various outcomes. Retention largely hinges on that period of time when the patient starts receiving ART or receiving ARVs. And during that period, before those outcomes of interest are seen, we would like to engage that patient in care. So retention helps us focus on this period of the continuum of HIV care. When it comes to M&E, there is some new terminology which is coming up, which I thought we needed to share at this point, so that when we are discussing M&E issues, we are all on the same page. The new terminology largely comes about because there's need to focus on the patient. So the new terminology is more patient-centered. And when we talk about retention, in the past, retention was a characteristic of a facility or a program. How many patients does it have in care? But with the new patient-centric approach, we are talking about the continuity of care for that patient. There are times where we used to talk about loss to follow-up, meaning how much loss has the program suffered, which they are unable to follow up. But patient-centric approach requires us to think about patients, and we ask the question, how many patients have had interruption in their treatments? So IIT, sorry. So that replaces the loss to follow-up. It basically explains the same thing, but the wording itself, the terminology is much more patient-friendly or patient-oriented. And the definition now for interruption in treatment, IIT, is number of clinical contacts or drug refills, or rather no clinical contact or drug refills having been seen for a period more than 28 days since the last expected contact or appointment. So if after 28 days we do not see a patient, for whatever reason we wanted to see that patient, be it for a clinical review, a lab appointment, or a pharmacy refill, we consider that as interruption in treatment. There's also another term which we've always used, that is defaulter. Again, this is from the program point of view, but from the patient's point of view, it's when a patient refuses treatment for whatever reason, or stops that treatment for whatever reason. So this is the new terminology, which we just keep in mind. We may, I think, find in the short term, people will be using these phrases or terms interchangeably, but they basically mean the same thing. Right, there are various ways in which we can measure retention in care, RIC. We can focus on looking at missed visits. We can look at appointment adherence, visit consistency or constancy, or we may even look at combinations of these as we describe retention in care. And the graphic there just shows some of these concepts in a graphical way. But what this tells us is that measuring retention in care can be a complex process because of these multiple metrics. There is no gold standard. And also depending on the setting, like if you're in a resource limited setting, retention in care can be measured in one way, which is different from that of developed countries. In Zambia, most facilities are now using the PEPFAR MER 2.0 indicators, and we are currently using version 2.5. What are some of these key indicators that we see in the MER 2.0 version 2.5? The key indicator for retention is TX curve, which is for TX or treatment current. That is the number of adults and children receiving ART within a given period. The other indicator is TXML, which is short for mortality and losses, and that is the number of ART patients with interruption of care as a proxy for these various losses. Again, the definition of 28 days since last expected contact is used. And then there's another indicator, TXRTT, that's treatment return to care. This looks at the number of ART patients who experienced interruption in treatment within the previous period who restart ART. Basically, this indicator looks at those that return to treatment or restarted on ART. These are the key indicators that we track in most facilities. Now, like I said, there are other measures, and depending on what you're trying to achieve or show or demonstrate, you can use other indicators. But these are the key ones that we use based on the MER 2.0 provided by PEPFAR. These indicators interact in a certain way to describe the nature of the ART population in a given facility or program. And we'll look at two very key areas, that is accretion, which is basically increase or growth by accumulation of the TX curve, and attrition, which is, I think, the more common word that people understand, which is looking at reductions of the TX curve through losses. The accretion, which is building up TX curve in simple terms, is taking your current treatment at the beginning of the period you are exploring or investigating, and adding to it those that transfer in, and also those that have been newly started on ART. These are patients who have never taken ARVs before, and they're now starting ART. You add that to those that are restarting treatment. They have had an experience of interruption in treatment. They have been tracked and they've been found, and now they are restarting treatment. So these will build up to the expected TX curve. On the other side, we don't end the story on expected TX curve, because we know in reality, we do lose patients for various reasons. This could be because the patients have died or transferred out, or they've refused to continue their treatment. And this should be taken out of the expected TX curve so that we can end up with the actual TX curve. And the big bucket is the IIT, which is interruption in treatment. In fact, this is the default. You have to be categorized as having died or transferred out or stopped treatment. If you are not categorized any other way, we place you in the IIT. In the past, we used to have a bucket known as unknown status, but that is being discouraged so that every patient has got a status in any of these buckets. We need to know what's happening to our patient. The unknown bucket is no longer encouraged. So if we remove these from the TX curve, we end up with the actual TX curve for that facility at the end of the period being looked into. A special note is on the trans-in and transfer out. The condition of that patient as they are transferring in or transferring out of the facility needs to be made of remark so that the patient receives the appropriate attention and treatment. Sometimes patients are transferred out when they're not doing so well. They are sick, they've got opportunistic infection, they are unsuppressed. So wherever they are going, we need to have them taken care of appropriately. And some of them do transfer in also a poor condition. So that's why the trans in and trans out, we need to make mention that their condition must be of note. So at this point, we'll stop for another polling just to see how much we can learn from today's sessions. Dr. Sombo.
Thank you so much, Dr. Mwango. Let's mute our microphones. Please mute the microphones. The following are considered beneficial for improving retention, except which of these are considered beneficial for improving retention? Peer navigators, same-day initiation of ART, TB symptom screening. The following are considered beneficial for improving retention. Remember, from what we have learned, retention is these patients that are receiving ART already. Remember, you've made a diagnosis, you've linked them what helps us keep them in care? Retention in care is the term. The following are considered beneficial for improving retention in care of patients. Is it A, peer navigators, B, same-day initiation of ART, C, standalone clinics, meaning you don't integrate your clinic, you are testing here, they are picking drugs up from here, they are doing family planning from another clinic, TB from another clinic, D, TB symptom screening. We'll allow a few minutes. These are the hallmarks of the good poll questions, Dr. Mwango. It's almost equally distributed across the board, which is, it's interesting. We'll end the poll now and just allow you to view how that looks.
Right.
As you can see, yes, almost half feel that the standalone clinics are not helpful to keep people in care, but there's a few who feel it's the others. I'm sure we'll elaborate on that later. Thank you all for polling.
Right. Thank you so much, Network, and thank you so much, Dr. Sombo. We'll look into the coming slides now, and hopefully it will provide some insight into that polling. What I did in this section, because we'll be focusing on the gaps in retention, I've started with the various ART population groups, and then I'll end with the general. Usually it's the other way around, and I find that disadvantages these groups. So we'll start with looking at there's a cascade there for engaging women that are pregnant. Some areas which are in blue, light blue, and light green. The first one, which is circled, is the point at which we engage pregnant women into the HIV care cascade. And usually what has been seen is that facilities with or programs with very poor retention have this activity very low. And it's largely due to low early ANC engagement. If you don't have a patient, you cannot retain a patient. So that's poor retention in its own definition. And that's a big problem with ANC. The other one is delayed initiation of ART. We test, we find that this woman is positive, but then we don't have rapid ART initiation. And that is also a problem for retention, because remember, retention is, we are aiming for specific outcomes. And usually the outcomes in ANC are that we don't have transmission of the virus, and we have a healthy mother who is virally suppressed. So by delaying initiation of ART, we are actually affecting negatively our retention. There are others that I've listed here, but I've only pointed out these first two because these carry the majority of the gap in this population. Other things are like prolonged waiting times, multiple adherence counseling sessions. It will be interesting to see how the new policy of having monthly visits for the 9 months of pregnancy will affect our retention, especially that we've seen in previous settings that multiple adherence or even clinic visits do negatively affect retention. We now look at HIV-exposed infants. Again, deficiencies in diagnostic supplies. So if you delay diagnosis, you are negatively impacting on retention. Perceived complexity of ART for pediatrics is also another area. A lot of people are afraid to touch children because they feel uncomfortable or they feel ill-prepared, untrained. There's a gap in the human resource required to provide these services. And the children are vulnerable because they depend on caregivers who decide whether their treatment is important or not. And then we have situations where there's concurrent malnutrition. I have seen parents deny ART to their children because they say, we don't have anything to feed them. And we know that ART is going to require us to make provisions of food which we cannot afford. So that is a problem in itself. And also having other concurrent infections like TB. For older children, adolescents, and young people, one of the major gaps is not having appropriate, comprehensive, age-specific packages. We feel and we treat children of different ages as if they are all the same, but their needs are very different. So we need packages that are going to provide appropriate care for them. Late diagnosis and poor access to ART is also another challenge, especially in the slow progressor population of our children. There's also a range of social and emotional factors that are associated with being an adolescent, and these have to be catered for. There's fear of interrupting school schedules, or for the young people, their work schedules, and there's cost to accessing treatment. For TB, HIV co-infected populations, and even other comorbidities, we know TB poses as the highest risk of morbidity and mortality in our population in resource-limited settings. So this makes it a very challenging program for retention. The deaths are usually recorded because of TB infection. Lack of integrated services and poor linkages. Patient has to move from one place to the other just to get all the services for HIV and TB or any other comorbidities. This makes it very difficult to retain patients. Patients will sometimes usually just die undiagnosed or untreated. And then there's also that fear of TB diagnosis, because in some settings, they equate having TB with having AIDS. Marginalized populations, men who have sex with men, people who inject drugs, sex workers, migrants, and a few other groups have very important social and situational factors which we need to take into consideration, which affect retention and uptake, such as stigma, discrimination, unfriendly environments, and ultimately social exclusion. An important aspect which we should not forget is inaccurate documentation. If our systems are not tracking retention, which can be a complex M&E issue, we'll end up with patients being miscategorized and placed in status which are not appropriate and hence hidden from the services that they need. Patient who has had interruption in treatment may be categorized as having died when they are not actually dead, and we should be tracking them. Or maybe they're in a DSD and we feel we have lost and we can't find them. They've transferred out, or it's a silent transfer. So all these categorizations may affect the way that we manage retention. Managing retention requires good decisions, but decisions are only as good as the data they are based on. If you've got poor data, decisions will also be poor. The general population basically is the final bucket that collects all the retention gaps that we can think of in our programming. But I've highlighted 3. In your own time, you can read about the rest. Logistics for patients and for facilities, so that the provider and the one who's receiving the service come together. That is a cost or is an inconvenience. There are long lines at some clinics, they are crowded, and the opening hours are not convenient. There are also treatment-related issues, such as when a patient starts feeling better, they decide to stop ART. Or maybe they're just tired of the pill burden and they develop treatment fatigue. And in some situations, we've seen faith healing causing patients to stop treatment. Our monitoring of retention is very important. If we have poor monitoring, we'll not be able to track our patients. We'll have a lot of undocumented transfers or silent transfers, as we call them now, and situations where people are incarcerated will not receive treatment. And those that are always on the move, the mobile migrant populations. So these are some of the general population retention gaps that I wanted to mention, but there are many, many others, and you can read them up as you go through this. I will now focus on strategies for improving retention, and I've categorized this into three slides or three categories. The first one is to prevent losing patients. So that means we need to promote accretion. One, introduce systems like appointment reminders using SMS. Let us encourage better, more robust, unique identifier systems. Let's use different cadres to provide services such as community health workers through task shifting for community education, health promotion, and setting up community support groups. Introduce services which have not previously been accessible to patients, such as mental health and drug dependency services. I'm sure some of you have heard of the CETA program or treatment, which we're introducing in the facilities. This is a good way to go forward. We need to decentralize testing and care to the lowest community level, such as the health posts and community posts, as we are doing at CRS. And when we're at this level, let's foster collaborations with networks for positive people and faith communities. An important aspect of retaining patients is to have DSD. It not only reduces the number of stable patients in the site, it will free up time for the clinicians to see the more sick patients, decongest the facility, and if you are also providing multi-month dispensations, this goes to even reduce further those congestions. An aspect which will also appear in the next slide is that of tracking your restart patients, the patients that come back after they've been tracked. Let's not just bring them back into a facility and forget about them. We need to work with them so that they do not die. Corrective action. This is the second category, which basically focuses on reducing attrition. Use a prompt patient tracing system, and this will compose of a tracking protocol, late lists, any way that you can use to generate late lists, which alert you to patients that need to be followed up. You can use smart care, you can use an appointment system or register. That can help in these prompt patient tracing systems. Community tracking registers, tracking staff, which are usually on a volunteer basis, but that should be coordinated by a professional healthcare provider, and providing the necessary logistics. It may be phones, credit in the phones, or even transportation. Health education and close monitoring are very important, especially for patients who have experienced interruption in treatment. When they are found, traced back, and brought back, they definitely need to have re-education, and you have to boil down to what has caused their interruption in treatment so that you prevent it. So that is the corrective action that is required for all restarts. Engage patients with significant barriers. If you identify they've got significant barriers, engage them in enhanced adherence counseling or the CETA, which I mentioned earlier on. And very importantly, improve retention data quality and use. In fact, this point is also important as a prevention measure, but have good data. That's the key. And the final category is based on the different population groups. And I've only highlighted those that may be more significant for each group, but there are others which can also be utilized. TB, integration of TB HIV care is very important. Early diagnosis and treatment. and prevention using TPT. For PMTCT, use peer educators, peer supporters. This is very important. It's been shown to be very beneficial to retention in PMTCT. And again, integration of ANC with ART. For the mobile population, have proactive interactions with patients who are planning to travel. Know about those plans. Identify ART facilities near areas where they're going to travel. And if possible, I would suggest that we also start formally giving temporary transfer routes, because you never know how long they will be out there. They may say, I'm only going for 6 months, but they stay there for 8. If for 6 months you have not given a temporary transfer route, they will become, their status will change to interrupted in treatment. A temporary transfer route protects the facility and the program and the patient from this status. Pediatrics, let us integrate pediatric care with family-based HIV care. Peer HIV positive support groups should be set up for adolescents, age-friendly clinics, train providers to address adolescent issues. The models are out there, use them. Appropriate age-specific functional tracking systems need to be put in place. The way we track an adult is not the same way we track an adolescent or a child, because of the dynamics of that caregiver, an adolescent who's a fledgling adult. They are semi-independent. So the way we track them is very different, and we need to have very specific tracking systems. For the marginalized, my advice is we need to have providers that have KP sensitivity. All providers need to have this. It is within our society to provide KP sensitive services. Peer case management is very important, and also creating what is known as corridors of care. Patients who are marginalized will usually move from one facility to the other to avoid detection by that system and to avoid potential being pointed out as being a member of a marginalized group. So we can create drop-in centers, peer navigator systems, and safe houses along where these individuals will actually move. And let's avoid labeling our patients as KP in our M&E systems. So in summary, we have 5 points that I would like you to take as your take-home points. The first one is that retention requires appropriately managed patients engaged in care for the purpose of achieving well-defined clinical and health outcomes. Let's keep our patients in care for a purpose, not just to have our ATX curve, but to have healthy, virally suppressed individuals in our programming. Key point 2, retention gaps and interventions should be based on data-driven approaches, which utilize high-quality data from robust M&E systems. Remember, your decisions are only as good as the data that you are using. Point 3, systemic and patient retention gaps should be identified early, especially in various settings that we have talked about. Key point 4, strategies to improve retention should be patient-centric, integrated, and appropriate for various ART populations. And finally, key point 5, most effective retention interventions require scaling up DSD models. I hope this was able to shed some light on retention in our programming, and also will influence the way we manage our patients. Thank you for your attention. Dr. Sombo.
Dr. Mwango, thank you so much for that. Are you able to stop sharing your screen for just a few seconds as we interact and get some contributions from the network before we go to the polls? I hope no one saw the answer there. more.
Sorry about that.
No. So at this point, we'll get some comments from the network, anything that we want to ask, contribute, share in terms of best practices. Of course, a few things stood out to me. I absolutely agree with your suggestion on temporary transfer out so that they can have a new temporal home when they leave, whether they go to Kazungula from Lusaka, whether they go to Western Province, so that there is some sort of linkage and acknowledgement that you are still our patient, you are still in our care, and we still want to provide you care, whether you are moving from Southern to Eastern Province. This recommendation, I absolutely want to vouch for. Some people saw the answer, but you know, in class, we used to have people who would see the answer but still get it wrong. Huh? I've noted you. Someone has written the message, you'd better get it right. So we have Walia from Chipata Nursing School. Please go ahead. Walia, your video is on. You can please unmute yourself. Walia from Chipata.
Thank you so much, Madam. Though I came in a little bit late, so I find that you have already started. Yeah, the case of transfer of hereditary patients, yes, it's a cardinal one. And just like Mr. Mwango was saying, yeah, there's a little bit of a gap when it comes to transfer. Are you getting me?
We can hear you very well.
Oh, all right. Yes. So I think what he actually shared more light on is able to help us in order to ensure a perfect and a greater way of actually helping our patients. Yeah. So I was saying that it's actually important that we even maybe improve on the hello?
We
Hello?
can hear you. We can hear you.
Okay.
Please go
So
ahead.
I was thinking, I think the smart care as well, the smart care system, if it's well established, then it's able to help each and everyone, or the Ministry of Health to basically provide the much needed care. Because if the smart care, wherever that patient goes, is able to produce that one, and whenever it's inserted, at least all the data will be showed, and the care which is needed to be provided, I'm sure it will be basically provided.
Thank you so much from Chipata. Essentially is emphasizing the need to use smart care. I believe smart care,
Yes.
that's one of the reasons it was brought on board, to improve by using technology. Elvis, please go ahead. Elvis, please go ahead.
Good afternoon, can you hear me?
If you moved closer to your mic, it would be better.
Now?
Yes.
Okay, it's just an emphasis to all the practitioners. Please, let's add as much information as we could on the transfer letters, because most of the transfer letters I've seen, they are almost blank. You find a patient has been on ART for over 4 or 5 years, but nothing on the transfer letter, no investigations, no viral, nothing on the transfer letter. So it's just an emphasis. Let's add as much information as we could so that it is easy for the people whom that patient is going to carry from where the patient has ended from your area.
Thank you very much, Elvis. Essentially, Elvis is appealing to all of us that see patients. That includes me, that includes the rest of the network. Let's provide as much information to the person receiving the client It's extremely important. Documentation is everything, as Dr. Mwango said. I'm sure you saw that room that had a lot of documents. I can assure you that room was not made up because someone had managed to go through all those papers and switch on a TV. At the back of those papers, there was some TV. Chimwemwe, your hand has been up for a while. Thank you for your patience. Please go ahead. And Mr. Singongo, just after we attend to Chimwemwe.
Good afternoon, Network. My concern has actually been addressed by Elvis. I wanted to talk about documentation on the transfers. Thank you.
Thank you. So this is a second appeal to all of us, okay? We are all looking at each other, all of us, you know. I'm pointing at myself, I'm pointing at my friends. Let us make sure we give the next facility as much information as we can. Peter, please go ahead. Peter Singongo. You are muted, Peter. You are very much muted.
Okay, you're able to get me now. Thank you. My contribution is on the incarcerated, that is the inmates. I want to give a practical example that is being carried out here in Ndola, the way we help these people who are incarcerated. For Ndola, I'll give an example of Ndola Central Police. There's a team of officers who have been trained actually in HIV counseling and the related issues to do with ART. They come on a regular basis. If they run out of the drugs, in case, for example, a person has been arrested quite late and he has no drugs, those people, they are able to help the client identify the drug that he's able to take and at least give him so that he doesn't miss. And such clients, later on during the day, they'll be brought to the clinic where they'll be assisted by trained personnel. And basically, that's what we do here in Ndola for the inmates, either from the Central Police or from the prisons. Thank you very much.
Thank you very much, Mr. Singongo, emphasizing on the need to really engage patients and take that extra step when you are trying to keep a patient in care, because bringing them back and getting them to separation is harder once you lose the patient. So, Mr. Singongo, I really appreciate the best practice that you have shared. I'm sure you saw what Dr. Mwango said. We also need to work on patient literacy. Let's not just say, yendani ku pharmacy. At each visit, at least remind them, do you know the drugs you are on? You are on TLD. You don't have to be a rocket scientist to know that you're on TLD, but sometimes we are not communicating to our patients. So thank you very much, Mr. Singongo. I see that we have a hand from Dr. Mwamba. Please go ahead.
Thank you, Dr. Sombo. And thank you, Dr. Mwango, for a nice presentation. Indeed, retention is one of the gaps in fight. I want to share some few thoughts. There is better info data from a study that was conducted on the CIDAS, which actually, we do refer to the better info data so often, which discovered that actually 40% of patients that are recorded as lost to follow-up or no longer in care are actually still in care, but they are simply silent transfer, attending ART from different facilities. So I don't know if Dr. Mwango is able to talk just a little bit about the issue of unique identifier and as well as a possibility of interlinking the smart care, which will allow us probably to capture most of this silent transfer and also easy identification of patient and deduplication of patient. We do have so many patients who have the ART files in different facilities with different ART numbers, but by using the unique identifiers and interlinking the smart care, we might kind of reduce on that. There's been some discussion around that. I don't know if Dr. Mwango can talk about that in more detail. Thank you.
Dr. Mwango?
Yes, please. Thank you so much, Daniel, for that important point you've raised. And I did touch on it, but just really at the surface. Smart care, as it is designed now, has that capacity to provide unique identifiers. But the media in which this unique identifier can move from one system to the other is through the care card. But we have seen that most patients do not use these care cards when they are moving from one facility to the other. And it also goes to answer some of the questions in the chart where there's not enough information on that handwritten letter. But if a patient is transferred with that letter and a care card for the purposes of a transfer, it will contain adequate information which can allow us to address the transfer in or transfer out appropriately. But we do not usually do that. And even when the care card is there, clinicians do not take the time to look at that history and even talk to the patient to fill in the gaps which are not in that history, because the records that are transferred are also incomplete. So that's one level at which we can have unique identifier and tracking of patients from facility to facility. Looking forward, we are hoping that soon we'll be able to use a unique identifier which has not been used previously. But for those of you who may have registered for voting in the coming elections, your fingerprints were taken. Because wherever you go, you always have your fingerprints. You don't have to have that card. And if the systems are interconnected, probably on the cloud basis, like we are being told that we'll have a system coming up, we will be able to access these records wherever we are, so long as they are able to link to the cloud and we are able to take those fingerprints. So that's another way in which we can encourage good transfer of information, sharing of information between systems and facilities. I think in a nutshell, that's what I can say for now, and then I'll leave room for the other questions.
Thank you so much, Dr. Mwango, talking about that we need to be checking all the information on their care cards, encouraging people to move with their care cards from one facility to the other, because it carries all the information. But something very innovative that we may have soon is the use of biometrics. A lot of countries in the West use this. So you just use your fingerprint and they are able to transfer information. Please, when biometrics come, let us not say that it's 66. That is our medical information. But there's some brilliant suggestions, Dr. Mwango, and I think we need to talk about them. I think it's Andrew Mangala who says that when you are referring a patient, please put the facility phone number on that form so that they are able to phone you back. Did you check the kidneys? What was the other treatment? If your facility does not have a phone number, there is no harm with putting your own phone number so that someone is able to contact you and say, are there any special needs? How do we go about that? Phone number maybe what saves us a lot of time and retains a patient. At this point, I think Dr. Chatondo had something there. Okay, so there's something here from Jean, and she says that we have had challenges with card readers for smart care, hence the challenge for continuity of care. I don't know if Chatonda, you want to comment on the card readers, or we are too echo now. It's not your problem. Do we have anyone from IT, the card readers? Mwila, any comments on the card readers? We'll put it in the parking lot if someone has a comment on, I wish we had Broadwich. I don't know if Dr. Kaya is here. To talk about the card readers. Some of them don't read, the patient has traveled with it, and then it's not working, and that puts off people using them. And they just say, well, they are just wasting my time. So Kunda is from IT here at UTH, and she can elaborate.
So for the card readers, what I can say is sometimes if they're not working properly, it's because of the installation. You need to go back to the installation on how the software was installed. there's a patch that has, there's an upgrade that has that patches up the cards for the cards to work. Then if that is not the problem, also the cards themselves. Sometimes you may have gotten a batch of cards that are not working properly from the manufacturer. So it's good to test them before they're distributed to say they are working. So it's one thing, either the software when installing was not done properly to accommodate the card readers, or the cards themselves have a problem.
Thank you so much, Kunda. I hope that is helpful. One, please let's test the cards before dispatching. If you have a card reader problem, please inform IT. It means that there's a patch missing that they can actually get back to. Right now, we are going to go into our breakout rooms, but the National ART Advisor, Dr. Sivile, please go ahead. The floor is yours.
Thank you, Dr. Foloshi. Yeah, I just wanted to come in with the integration of the data from Smart Care. I think all of us, I don't know if we are aware that we are moving to the Smart Care Plus. That capability will be much, much easier. A lot of facilities have already moved. We also have the National Data Warehouse where this data now is flowing. It's actually functional, where that integration of data, these patients can be done and follow up. The other issue is for provinces that are implementing the CBS, which is also functional. That capability is being done, where patients' records from different facilities are being integrated so that patients are identified as silent transfers. I just want to mention the same issue of patients' records not being complete. This is just an edge to our partners out there. When we go through both the data warehouse data and the CBS database, the analysis shows that our data is really not complete. I'll give an example. I'll not mention a facility in Western Province. One facility, we had almost 80% of patients not having the HIV diagnosis on the file. So as you know, if you have to trace patients, these systems, they will pick them based on them having that information. So it's just an appeal that let's go back. You see some teams in some of the facilities, teams will be coming in to just re-enter most of these records so that they are complete, to do a backlogging and things like that. Yeah. But let's make it a habit that we don't only enter a pharmacy form, as I've seen in some of the facilities, that even just the general clinical follow-up form, diagnosis and things like that, all those things are entered. But otherwise, to just alert everybody that there's a CBS system, it can give you the data. Right now, the CBS team is asking, you know, who is inviting, who else is interested to use that data. Western Province, a very good example, how this data is being used to follow up these patients. And I think Lusaka Province is helping as well, is trying as well. And also the data warehouse, you can reach out to us, see how that data can be used to follow up these patients. So these systems are available and they are running. I submit, Dr. Foloshi.
Thank you so much, Dr. Sivile. I'm sure we've all heard what he has said. A lot is being done to improve, including Smart Care Plus, which will be easier. Please go ahead and cast your vote. Dr. Mwango, please reshare your slide deck so that we discuss the answers. You can see how much retention of information is there. Retention in HIV care focuses on A, clinical outcomes, B, how long a patient is engaged in care, C, all of the above. Dr. Mwango, please share your slide deck. Please share your slide deck. Retention in HIV care focuses on A, clinical outcomes, B, how long a patient is engaged in care, C, all of the above. I'll share from my
You're
end.
sharing? Oh, okay.
Yes, I've decided to just share. I'm just going to end the poll and you can have a look at how well you taught. Any comments, Dr. Mwango?
Yeah, like you indicated, the retention has been good for this question. And we can see that people have appreciated that clinical outcomes are part and parcel of retention. And also, of course, the recognized duration or longevity of that engagement in care. So those two things go into the definition. And when you look at the definition itself, these two components are inherent in that definition. The engagement and the purpose is that of having a particular outcome in mind, clinical or health-wise.
Thank you very much, Dr. Mwango. The following are considered beneficial for improving retention in care of patients, except with A, peer navigators, B, same day of ART, C, standalone clinics, D, TB symptom screen. The following are considered beneficial for improving retention in care, except which one does not improve? Is it peer navigators, same day initiation of ART, standalone clinics, TB symptom screening? Dr. Mwango?
Yeah, again, this is an improvement on the previous. I think the casting was split almost equally on all four stems previously, but now we can see there's a dominant response of agreement as well, showing that standalone clinics do not promote or improve retention. And this is true because we've seen in two very specific groups, pediatrics and TB groups, there's a core to have integrated services, meaning the clinic for, in fact, three, even the ANC should not be on its own. The TB should not be a TB corner in an isolated corner. And also the adolescent and children's clinic should not be in isolation, but they should be integrated with family-based care. So really integration is the way to go. Have all the services in one place as much as possible. Don't have patients moving all over the place, because once they get frustrated, the only exit they'll look for is the exit outside of the facility. And that's it, you will lose that patient. So really, standalone clinics is the exception. Peer navigators are very important. We've already heard examples of that. Same-day initiation hinges on the area of treating patients almost immediately that they require treatment. We give them the ARVs. TB symptom screening is really a mark of not delaying diagnosis, because if you delay diagnosis, eventually the patient will think maybe it's COVID that I have, that's this explanation for these TB symptoms, and they want to run away and do something which is not conventional. And so immediate diagnosis and immediate treatment with the help of peer navigators helps retention, but standalone clinics do not. That's the exception, and that's the correct answer. Thank you.
Thank you very much, Dr. Mwango. As we now go into our breakout rooms, I'm getting the flag up. We've run out of time. We are waiting for our breakout rooms. There's a comment from the Iron Lady. There's someone called the Iron Lady who's saying that, please, let's update our records if we have private patients or maybe people that want to remain anonymous. If you do dispatch drugs, please let's update the records. She had a client since 2013 has been accessing ART, but there's no record of this client. Please let's update the records for these patients that need to remain anonymous. Okay. We are waiting for our breakout rooms. Just to mention that we are adding Dr. Zico to Southern Province, Dr. Maria will join Western Province, and Dr. Kankasa will also join the expert in Eastern Province. Other experts in these rooms will include
Good afternoon, everyone. Welcome to Southern Province breakout room. I'm Dr. Jackson. I'll be the facilitator for today. Just want to confirm if Pemba District has joined in. Masao Sotembo or Mr. Njovu, kindly confirm if you have joined the network. Anyone from Pemba Main Clinic that has joined? Or anyone to confirm if I'm audible enough?
Yes, you're audible.
Okay, thank you very much. Anyone from Pemba? Looking at time, anyone that Masauso or Mr. Njovu? Okay, so as we wait for the team, the case presenters to join us, I'd like to take this opportunity to welcome you all. Our experts for today, for the breakout, to be Dr. Sombo, Foloshi. Dr. Foloshi, have you joined us? Okay, Dr. Albert Mwango, welcome. If you have joined us, just confirm with me if you are on the call. Okay, Dr. Zico, welcome. If you have joined, just confirm with me if you are on the call. Okay, so I suppose maybe other experts or the presenters might have joined another breakout group, and I think they'll join us during the course of the case. I think for now, I've seen we have quite a number of other experts. I think from Southern Province, there's Dr. Piri, there's Dr. Sakara, Dr. Mwemba. Also, I think I've seen from CIDAS, Dr. Mwamba Daniel has joined us. So I think the experts who are able to join us, you can pick it up. So Mr. Masao Sotembo Jovu, if you have not joined, I'll go ahead and present the case on your behalf.
Dr. Jackson.
Yes, please.
Its member has been taken to Western Province.
Okay. Okay, I guess they are still asking if they could be joined, and they will join us, I think, due to time. Okay, so I think I'll go ahead and present on their behalf, and then they'll join for recommendations as we proceed. So we're looking at a 17-year-old girl, adolescent, that tested positive for HIV on the 16th of May 2016, and I was initiated on a TOE, that is on the 17th of August, of July. Of August 2016, that's 2 months later. And then I came in to the facility that is Pemba Main as a transient in April 2020 with unsuppressed viral load, and I was enrolled in IAC. So from there on at Pemba Main, her last pharmacy pickup was on 30th of April, that was 2020. That was the time that she was transferred at the facility. And then it was reported that she missed her subsequent appointment, which was scheduled a month later, that is on 28th of May. So follow-ups were made, but do not yield anything. That is a phone visit, phone and home visit. Her treatment was interrupted up until 24th of August, 2020. That was 3 months later when she was brought back to care. So the uncle, that is the one that helped the facility to locate her, and it was discovered that she had traveled out of town and that she was cohabiting with a man of a non-HIV status. So upon reactivating her back into treatment, she was enrolled into IAC. Viral load, genotype, and other labs were collected following completion of IAC sessions on the 26th of November 2020. That was from August. And on 18th December, results came back to the facility, and they were still unsuppressed after undergoing 3 months of IAC, and she was switched to second line on 24th of December 2020. So the drug history is that she was switched to DTG-based regimen upon receiving the results, and also was commenced on TPT for TB prophylaxis. So her socioeconomic status is that she's a double orphan, and she's a grade 9 dropout. So there's stories that also she has been in and out of town under the custody of different guardians. Apparently, she's staying with her uncle now, who is a peasant farmer. So on a physical examination, when she came last visit, that was on 28th of January 2021, generally she was stable, doing well, and her BMI was around 20. BP was normal, the pulse and other physical examination were unremarkable. So this is just a timeline of the labs that I just mentioned. And so as you can see, she was initiated on TOE after 2 months of being diagnosed with HIV. And then the first viral load, which was done on February 2020, that was last year, a year ago, was 75,918. And the second viral load that she had was on 18th December 2020, and that was about 10,000 copies, 10,065 copies, and she was switched to second line upon receiving the results. So that is also the CD4s. The first CD4 was in November, in February 2020, when they did the first viral load, which was 484. The baseline CD4, where we do not have a record. And the second CD4 was done when they repeated the viral load, which was on the 18th of December again, 2020, and was about 489, the same range. So IHP and urea creatinine were in the normal range, as well as ALT. So these are the questions from the facility, Pemba Men. What else could have been done better to return this adolescent OVC into care? What other interventions should we take to return her into care if similar situation? So not sure if Pemba Men has now finally managed to join in. Just confirm, since these are the ones that will be getting these recommendations. Pemba Men, anyone to confirm if Mr. Masao Sotembo or Njovu, Mr. Njovu, or anyone from Pemba? Okay. So since Pemba, I'll take it up. I'll turn on Pemba, take the recommendation, and I will submit to Pemba Men. So first of all, if are there any questions? Unfortunately, I'll not be able to answer all the questions since I'm not from the facility. We can, any other clarifications or questions that the network has for the facility, and then we can pick it up with the experts. You can free unmute, just interrupt and go ahead.
Good afternoon, Doc.
Good afternoon, Mr. Aka.
Yes, mine is, I was trying to look at, maybe we can just kindly go to the VO results. The VO results. Yes, maybe as that is coming, one thing that I've noted is that when the client was enrolled in IAC, the viral load was 75,918. Then after IAC, what I've noted is that it actually even reduced from 75 to 10,065. So the question I was trying to ask myself is, in view of this, one thing that is there is that, yes, because the client is of no fixed abode, would go stay maybe elsewhere and maybe move to some other places. So I see that could also have contributed to maybe poor adherence. Maybe probably the reason that has been given is that now she's staying with the uncle, and maybe because maybe there was that stability in the way the client is. Maybe that's why we've seen the reduction in the viral load. So at this point, I was asking myself to say, was it maybe at this point, would it have helped for us to be able to do to give the client maybe
issues of ensuring it's being updated in smart care, ensuring that people understand how to use the smart care so that the drug dispensation is dispensed correctly in smart care, especially with children. We found that sometimes the way the drugs are dispensed is not really how, it doesn't add up to when they're supposed to come back into care. I think that's what I could contribute.
Thank you very much, Dr. Lugano, for lead contributions. So the next question is, how best can we improve feedback on silent transfers between facilities? How best improve feedback on silent transfers between facilities?
Good afternoon.
Good afternoon. Thank you.
Okay. This is Chimamwe Piri from Mehari Kanyama.
Yes, you can go ahead.
Most of the times, these the silent transfers, they will visit the facility to say, no, I'm accessing treatment from such a facility, or I was accessing treatment from such a facility. So in order to track the real information about these silent transfers from their facilities, I think it would be advisable to come up with a director for these facilities of how best we can contact the facilities to get more information about the clients that we receive in a silent transfers from these other facilities. So maybe trying to build a directory like where we have phone numbers, contact details of the fellow facilities that we have within the province or within the district, so that it can be easy for us to contact those facilities as a facility who is seeing that client at that particular time. Thank you, I submit.
We need to use director like the initiative with these facilities. Says we need to empower treatment supporters to benefit giving contact this information echoed by or medical with the class. The next follow up very helpful with patients with no valid phone numbers. Also, home deliveries home can help retention. Feedback can be where a client is coming from, that is if the client is how best can we track recipients who are late for more than 100 days? How best track recipients of late for more than 100 days?
Good afternoon once more, Doctor. Hello.
Well, you can go ahead and give your contribution. To hear you.
Okay. Yeah. So most of the times that we have seen is we are really losing clients because most of our patient locators are not like updated. You might find the patient started treatment 15 years ago or 10 years ago, but you find the patient locator is still the same locator when people started. So every now and then, as we have interaction with these clients, we should have updated patient locators, which are more or less like give us correct information. So that even when the patient goes, we'll have latest information of how to track and locate them. I submit.
So we'll soon be going back to the. So at the last person attributed that we need to get our location. We need to enhance. Then we have Dr. Centered approach. Then we have someone
and facilitators who enabled all our provinces to have fruitful discussions. I was in Lusaka, Dr. Mwenya facilitated discussion. And essentially the conclusion is that data is everyone's responsibility. If something new comes up, like a new locator, it's your responsibility to update it. Remember, patients don't write in these files, eh? So they are relying on us as healthcare workers to write what they tell us. So please, data is not it's not an IT problem. It's not a nurse problem. It's not a doctor problem. It's all our responsibility. At this point, we'll allow our colleagues from Eastern Province to give a very brief summary of their discussion.
Hi, Dr. Sombo.
Dr. Piri, please go ahead.
Yes, so the case that we had, this is a gentleman that was accessing treatment and had a lot of gaps in treatment. Stopped after about 1 year, 2 months or so, then brought back into care. And this client was collecting medication through a CBV, who's a treatment supporter at the same facility. So one of the key things that was done is that they collected a viral load after the first reactivation of this particular client. That's on the same day. So one of the things that we discussed on was that the collection of viral loads needs to be collected after good adherence, after being on treatment for at least 6 months. So we treat this particular client more or less like a new client. Then at that point of reactivation, we need to make sure that this client is re-educated, certain aspects of
We've lost Dr. Piri. Madam Nomsa, are you with Dr. Piri?
Unfortunately not. I'm not. I wasn't even in the breakout room. I was in the Lusaka one, so I can't give a feeling.
Okay.
So Dr. Foloshi, we're together with Dr. Piri and the team in Eastern Province.
Dr. Kalasa, please pick it up. Thank you so much.
And just to add, of course, time was a constraint for discussion, but just to help the team, indeed, there are a number of factors that we need to look at, but it was in pure agreement that there was actually need to engage the patient better. And this could have been missing from the side of the team on the ground. Going forward, it would be great to ensure that the patient is closely engaged on possible patient factors, social factors that could also actually impede the desired adherence to treatment. But also a lesson, the CBV comes in, who happens to be the nephew, comes in with good intentions, but this is a lesson to all of us. A relative at a facility should not replace the healthcare systems that actually exist. What they could have done is to work very closely with the care team, even at the level of the community health worker who is in charge or tasked with the responsibility of following up this particular client. They needed to work with them very closely to ensure that the ultimate assistance is provided to the patient. There was a comment, of course, on having to take viral load immediately the patient came back or reactivated on care. This was seen as perhaps as a gap in following the treatment guidelines. And going forward, it should have been done after 6 months and then subsequently 6 months, and we follow through like we always do on an annual basis. So that was the addition for the Eastern Province. Thank you, Dr. Foloshi.
Dr. Kalasa, Eastern Province was so lucky to have you. You picked it up very well, and thank you for delivering that message in a cool, calm, and collected manner. I particularly liked your point about a healthcare worker, meaning me, I should not replace the system. One, it's not even encouraged, and this is how you end up with records missing. Thank you so much, Dr. Kalasa. Thank you all for attending this session. And sincere gratitude to you, Dr. Mwango, for really opening up this very important topic on retention and really giving us the breakdown and introducing us to new terms such as IIT, interruption in treatment, as opposed to saying lost to follow-up, which sounds like there's no hope, we are lost. So thank you very much, Dr. Mwango. We always appreciate having you here. Next week, we have Wedi and the TB team, and they will be talking about management of TB. Thank you.
Yeah.